this week we were kind of on vacation, but next week, next Thursday, we are going to have a very interesting big webinar, a masterclass about cardiac intensive care. It's going to be the second part. The first one was amazing. If you didn't have the chance to watch it, go to YouTube and take a look. It was very nice. And we are preparing very nice things for this Thursday for you on the cardiac intensive care webinar, and it's going to be awesome. It's going to have journal club with the first authors of important papers presenting their research, and we're going to have very nice lectures and, as usual, a lot of discussion. So please join us on next Thursday. And on the other week, on the Thursday, September 24th, we are going to have an amazing surgery masterclass. And we are going to have, this is the second part as well, and Dr. Nikaido, who developed the Nikaido surgery, is going to be our keynote speaker. I'm going to place the links on your chat box, and you're going to receive them on email next week as well, so please join us. And today we are very happy to continue the Functionally Univentricular Heart series with Dr. Anderson. Today we're going to talk about pulmonary atresia and with intact ventricular septum, and we really hope that all of you can join us on discussion. This is a unique opportunity that we can have Dr. Anderson available to answer all of our questions and listen to all our comments. We are happy to have Dr. Norman Silverman as a panelist today once more. So all of them are going to be able to answer your question and discuss with you about this morphology of pulmonary atresia, intact ventricular septum. So thank you very much, Dr. Anderson. We are very, very happy to have you with us again. Thank you for your time, your knowledge, and your kindness.
Today is understand the anatomy that we find in the setting of the functionally univentricular heart. So as you see, we have to ask the question, why are the ventricles each incapable of supporting an independent circulation such that only one of the ventricles can fulfill the role of pumping into the circulations? And there are basically three reasons why we might find this. So in the first instance, there can be, during development, inappropriate sharing of the inlets and the outlet components with the apical trabecular components. And very shortly, I'm going to show you how this sharing takes place normally. So if we have inappropriate sharing, in essence, that gives us what we now know is the univentricular atrioventricular connection, because it's the failure to share the inlet parts that is the key to producing the ventricle that is incomplete with and incapable of pumping into the systemic circulation. We can also, however, have functionally univentricular hearts when the inlets have properly been shared between the ventricles and we have a septal defect. And that is what we see when we have ventricular imbalance. And that is perhaps best seen in the setting of atrioventricular septal defect with common atrioventricular junction. And in that setting, when there is right ventricular dominance, then the left ventricle is incapable of supporting the circulation in many instances, and the option there is to move towards functionally univentricular repair. But today, when we discuss pulmonary atresia with intact ventricular septum, I'm going to show you how development has progressed normally such that the embryonic interventricular communication has closed so that we have two normally constituted ventricles, but that one of the ventricles stops growing. And in this instance, pulmonary atresia with intact ventricular septum, which we're going to be discussing today, it is the right ventricle that stops growing, or rather, as I will show you, the cavity of the right ventricle is overgrown by gross mural hypertrophy. And next week, we will discuss hyperplastic left heart syndrome, and that for sure is the situation where, for reasons that as yet we do not understand, the left ventricle stops growing, having initially been normally constituted. So let me continue, and let me emphasize for you the difference between a hypoplastic ventricle and an incomplete ventricle, because they are not necessarily the same. So a ventricle that is hypoplastic has a deficient cavity, and it can lack one or more of its normal components, but as we are going to discuss today, the ventricle can be hypoplastic when it is normally constituted in terms of its component parts. This is in contrast to the incomplete ventricle. The incomplete ventricle from the outset lacks one or more of its normal components, and hence almost always will additionally be hypoplastic. And this is the key difference. Everything depends on what happens during development. So let me review again with you the key steps of normal cardiac development. Because we now know when the heart is first formed and after we have had what's known as ventricular looping, the atrioventricular canal is supported exclusively by the developing left ventricle, while the outflow tract is supported exclusively by the developing right ventricle. And it is the sharing of the inlet and outlet components between the apical trabecular components that is the key to formation of the normal heart, and this requires remodeling of the initial embryonic interventricular communication. So those of you who were with us in the Congenital Heart Academy when we started our presentations will have seen this picture before. This is a reconstruction of a human embryo. The human embryo is about 5 weeks old. It's what we call Carnegie stage 13. This is one of the reconstructions made by my colleagues working in the University of Maastricht, Professor Wout Lammers and Dr. Jill Hickspoors. And Wout and Jill have produced the most amazing series of reconstructed human embryos from Carnegie stage 12 through to Carnegie stage 23, which is where we stop talking about embryonic development and we start to talk about fetal development. But this is the early stage shortly after we have seen formation of the apical trabecular components. So what you see there is the connection between the developing atrial chambers and the ventricular loop. And we call that the atrioventricular canal. And what the reconstruction of the cavities made by Wout and Jill shows you is that at this stage, the atrioventricular canal is supported exclusively by the developing left ventricle. And you see there, ballooning out from the outer curvature of the ventricular loop, the apical trabecular part of the developing left ventricle. To your left hand, ballooning out from the outlet of the ventricular loop, you can see the developing apical component of the right ventricle. And what you will then immediately appreciate is that the right ventricle is supporting the entirety of what, with fullness of time, will separate to become the ventricular outflow tracts. Now, I can also show you what this looks like by going to one of the episcopic data sets that we have prepared from human hearts at similar stages of development. This one is marginally later. As you see, it's Carnegie stage 14. This is a section across the ventricular loop in a data set prepared by my friend and colleague, Tim Mohan, who was working at the Crick Institute in London and developed this technique called episcopic microscopy, which permits us to section the three-dimensional data sets just as you, as clinicians, now section data sets with computed tomography or with magnetic resonance imaging. So what you are seeing here is the base of the developing ventricular mass, and you're looking at it from the apical component of the developing ventricles. So there you see the ventricular surface of the atrioventricular canal. Within the canal, you can see the cushions that are guarding the junction between the developing atrial chambers, developing ventricular chambers. But as you see, and as we saw from the reconstruction of the cavities, at this early stage, the atrioventricular canal is supported exclusively by the apical component of the developing left ventricle. As I showed you, to your left hand now, at the outlet of the ventricular loop, we can see the ballooning component of the developing right ventricle, and the episcopic picture shows you very nicely how the right ventricle is supporting the entirety of the outflow tract. So what this means is that all the blood coming from the atrial chambers passing into the left ventricle has to pass through what we can now call the primary interventricular foramen so as to reach the outflow tract. And that means that the embryo cannot close this primary interventricular foramen. Now, this is another picture of the same data set, and I've cut it to replicate what you as echocardiographers can produce, the subcostal oblique cut. And now what you see is the cavity of the right atrium, and beautifully you see how the cavity of the right atrium has no communication with the developing right ventricle. In fact, at this early stage, the developing heart is mimicking what, in the postnatal stage, we now call classical tricuspid atresia. We can see here the apical trabecular component of the developing right ventricle. And at this early stage, as you saw a moment ago, the right ventricle is supporting the entirety of the outflow tract. So there you see the primary interventricular foramen. And the embryo cannot close that primary interventricular foramen because all the blood from the left ventricle is flowing through that to reach the outflow tract. But I hope you will immediately note the similarity with classical tricuspid atresia. Because, as we will discuss in a couple of weeks' time, the essence of classical tricuspid atresia is absence of the right atrioventricular connection. So as we saw at that early stage, the right ventricle possesses its apical component. It now possesses only one of the outlets because in the ongoing development, the outflow tract has separated, and the aortic outflow in this instance has been committed to the developing left ventricle, but all the blood going to the pulmonary circulation has to pass through the embryonic interventricular communication. So that right ventricle was incomplete. But if development proceeds normally, as you see here, in the next stage of development, it's another episcopic data set of a developing human heart. We've gone from Carnegie stage 14 to Carnegie stage 15. You see the crucial remodeling of that primary interventricular communication. Because now the right atrium can get directly into the developing right ventricle because there has been expansion of the atrioventricular canal. And it is that expansion that remodels the dorsal part of that primary interventricular foramen. And we can see that by tilting the data set and again looking at the base of the ventricular mass from the apical component. And there you see how the expansion of the atrioventricular canal has remodeled the primary interventricular communication such that now the right atrium can communicate directly with the right ventricle. In other words, by expanding the atrioventricular canal, by remodeling the interventricular communication, the embryo has created the inlet to the right ventricle. So this is what it looks like in a mouse heart just after this expansion of the atrioventricular canal. You're looking at it again in what echocardiographic terms we would consider an oblique subcostal cut. And you see that because of expansion of the atrioventricular canal, the right ventricle has now achieved its inlet. But at this stage, pulmonary root, the aortic root that are separating in the distal and intermediate parts of the outflow tract are still supported above the developing right ventricle. So that means that the persisting part of the interventricular communication can now be considered a secondary foramen. And in order to close that foramen, we have to transfer the aortic root into the left ventricle. And this requires the next stage of remodeling of the interventricular communication. So this is that data set I showed you just a moment ago. I've rotated the cutting plane so I can show you a 4-chamber cut. And you see that there has been expansion of the dorsal part of the interventricular communication. That has produced the inlet to the right ventricle so that the blood can now pass directly from the right atrium into the right ventricle. So there is the right ventricle that has its inlet, but at this stage, it is still supporting not only the pulmonary root, but also the developing aortic root. And that means that the blood that is coming into the left ventricle, so as to reach the aortic root, has to pass through what we can now call the secondary interventricular communication. And in order to close the ventricular septum, the embryo has to build a shelf in the roof of the developing right ventricle so as to connect the aortic root to the left ventricle through the secondary interventricular communication. And we know that that is exactly what happens. This is another data set later on the same stage of development in the mouse heart. And you see that the cushions that divide the proximal part of the outflow tract have fused with each other. You can see the line of fusion between them, and that has now created the channel from the aortic root to the developing left ventricle. And this is what it looks like when we rotate our cutting plane so we can see it in 4-chamber plane, aortic root, still above the cavity of the right ventricle, but now the blood coming through the secondary interventricular foramen will connect the aortic root directly into the left ventricle. And there, just beneath the aortic root, you now see a persisting foramen. So we can call this tertiary foramen, and it is this tertiary foramen that will now be closed by the membranous septum to complete ventricular septation. So it is remodeling of the primary interventricular foramen, gives the right ventricle its inlet, and then with ongoing remodeling, as you see here, the left ventricle achieves its outlet, and only at that stage do we finally complete ventricular septation. So when we see hearts that have 2 normally formed ventricles, but one is hypoplastic, we know that whatever has produced that entity had to occur after the closure of that tertiary foramen. And so that is why we know that the lesion we're now going to consider in a little more detail, pulmonary atresia with intact ventricular septum, we know that it is an acquired disease of fetal life. And indeed, the fetal echocardiographers have now shown us this progress of events whereby they can see mothers who at an early stage of pregnancy have a normally developing right ventricle with ongoing development due to an insult, develop pulmonary atresia, eventually with intact ventricular septum. And what I'm going to show you is that the lesion is a spectrum. And the severity of the spectrum depends on the size of that right ventricle, which is normally constituted, but which has a hypoplastic cavity. And I think all the evidence now points to the fact that the size of the ventricle depends when, during fetal life, the insult takes place that prevents ongoing normal development. And indeed, we can extend the spectrum I'm going to show you today to include cases of what we can call critical pulmonary stenosis, in which the pulmonary valve is not quite atretic, which has a small centrally shaped opening, as I will show you. So remember, we must distinguish hypoplastic from incomplete ventricles, recognizing that the incomplete ventricle is itself often or usually hypoplastic. So here I'm showing you an example of the Holmes heart, double inlet, left ventricle, with concordant ventricular arterial connections. And I show you this picture to emphasize the similarity between the incomplete right ventricle we see in the Holmes heart, concordant ventricular arterial connections, and the arrangement that is usually found in the setting of tricuspid atresia. So there is the right ventricle, and it is incomplete because it lacks its inlet component. And in the heart you're looking at now, the Holmes heart, the right ventricle is incomplete because both inlets are connected to the dominant left ventricle. So in the Holmes heart, the incomplete right ventricle receives its blood through the interventricular communication, ventricular septal defect, if you will, exactly as it does in tricuspid atresia. So we should be distinguishing today those incomplete right ventricles, and we're going to look at those in a little more detail when, in forthcoming weeks, we will discuss atrioventricular valvar atresia, and we'll discuss double inlet ventricle. But today, we are discussing the right heart, which is normally constituted, but which is hypoplastic. And so here you see the hypoplastic, normally constituted right ventricle. In this instance, we'll discuss this again very shortly. It has an atretic infundibulum. It has an overgrown apical component such that the hypoplastic cavity is essentially only the ventricular inlet. And so, what we're discussing today, pulmonary atresia with intact ventricular septum, we can also think of it as the hypoplastic right heart syndrome. And if we look back, this has been recognized for quite some time. So John Hunter, one of the brothers who set up the anatomical laboratories and dissecting rooms in London in the back part of the 18th century, with his brother, he manned these dissecting rooms, and he noted when describing this entity that the right ventricle had barely any cavity, and he also noted the size of the right ventricle was proportional to the size of the tricuspid valve, which was especially small. So the key to the understanding of the size of this hypoplastic right ventricle in the setting of pulmonary atresia with intact ventricular septum is the overgrowth of the cavity by mural hypertrophy. And you will all know that we talk about these lesions in terms of tripartite, bipartite, and unipartite entities, but it is the cavities that are tripartite, bipartite, or unipartite, because in all of these hearts, the right ventricle itself is normally constituted, but its cavity is overgrown by mural hypertrophy. So here is an example from the better end of the spectrum. And I show you this one where I've taken away the parietal wall of the right ventricle because it shows you very nicely that the right ventricle has an inlet component. Right atrium is connected through the tricuspid valve into the right ventricle. There you see a nicely formed apical trabecular component of the right ventricle. You note, of course, apical trabeculations of this ventricle. And you see it also has a patent infundibulum, an outlet. So why is the right ventricle hypoplastic? It is hypoplastic because the outlet is blocked totally by an imperforate pulmonary valve. And I will return to that in just a moment. So this example of pulmonary atresia with intact ventricular septum, hypoplastic right heart syndrome, if you will, has a tripartite right ventricular cavity that you clearly see. The right ventricle itself is normally constituted, even though it is hypoplastic. But when we progress and we look at autopsy specimens, we can see the key feature, which is mural hypertrophy. So this particular heart was repaired by the surgeon who cut open the outflow tract and created a wide open outlet. But what you see, it has a nicely formed inlet. The outlet has been reconstructed, but in this entity, you can see the gross overgrowth of the apical component by the mural hypertrophy. And this is the key. It is the mural hypertrophy that obliterates the cavity. In this instance, a tripartite ventricle possessing all three parts, but a bipartite cavity, because the mural overgrowth has obliterated the apical trabecular component. So now when we look at the worst end of the spectrum, you will recognize this is the heart. I've already shown you the right ventricle, tiny cavity, the tricuspid valve is especially small. The cavity is essentially the inlet, because again, we have overgrowth of the apical component, but the mural hypertrophy has now extended up into the infundibulum and has obliterated the outlet. So once more, tripartite ventricle, but now we're at the worst end of the spectrum. We have a unipartite cavity. So I've also shown you the significance of the infundibulum. And let me return to that first heart that I showed you at the better end of the spectrum, because you see that in this instance, Anne takes the most exquisite pictures. And so here she has magnified the pulmonary trunk. We're looking down on the pulmonary trunk from its cavity. And there you see the commissures of the pulmonary valve. The pulmonary valve has formed, but it is imperforate. So we presume that whatever produced the atresia, the imperforate pulmonary valve in this instance, was relatively late during gestation. Because in other instances, and this is another of Diane's beautiful pictures, you don't quite have an imperforate valve. So this is what might also be called critical pulmonary stenosis, again with an intact ventricular septum. You see again the commissures, but this time the pulmonary valve has not quite become imperforate. So there is the typical feature of critical pulmonary stenosis. We have the dome-shaped valvar diaphragm, but it has a small central opening, often called the volcano-type valve. Critical pulmonary stenosis, the end point of the spectrum of pulmonary valvar atresia, here pulmonary valvar stenosis with intact ventricular septum. But this is what happens when we go to the other end of the spectrum, because this is what happens when the insult happens relatively early during fetal development. And not only does the mural overgrowth obliterate the apical component, it also obliterates the infundibulum. Because now, in these instances, the worst end of the spectrum, we can recognize the tri-radiating valvar sinuses, but they have come together in the middle of what should be the ventricular arterial junction. And now we presume that there was valvar tissue there at the outset, but it has become obliterated, so there is no way through from the ventricular cavity, which in this instance essentially will only be the inlet component, no way through, because there is also obliteration of the subpulmonary infundibulum. And it is this that is the worst end of the spectrum. To emphasize again, the essence of the lesion is overgrowth of the ventricular cavity by mural hypertrophy. So another key feature in determining the features we see in the anatomic sense is competence of the tricuspid valve, because there is another variant. Thus far, I've emphasized those lesions with pulmonary atresia and intact septum in which the right ventricle is small. There is then another important subset. The right ventricle is dilated in this instance, but it has thin walls. Not only is the right ventricle dilated, so is the right atrium. And this is because the tricuspid valve, during the remainder of fetal life in the setting of pulmonary atresia, has become incompetent. And this promotes the entity that we call the wall-to-wall heart. But there can be another problem with the tricuspid valve, because if the tricuspid valve remains competent in the setting of this gross mural hypertrophy, then the pressure can blow the blood into the coronary arteries, and this gives us the fistulous communications, and these are the bad prognostic feature of the worst end of the spectrum of pulmonary atresia with intact ventricular septum. So let's look at these two ends of the problems with the tricuspid valve. In this instance, we've opened up the right ventricle in clam-like fashion. There you see the level of the atrioventricular junction, but the hinge line of the septal leaflet, the inferior leaflet, tricuspid valve is rotated towards the ventricular apex. And this, of course, is Ebstein's malformation in the setting of pulmonary atresia with intact ventricular septum. The leaflets of the tricuspid valve are also dysplastic, and because of that, we have this gross dilation, not only of the right ventricle, but also the right atrium. And it is that progression that gives us what you see here, the wall-to-wall heart. And this is a terrible prognostic feature because the wall-to-wall heart has squeezed out the lungs. And it is the immature pulmonary development because of the pressure, the squeezing out produced by this wall-to-wall heart that is the reason these babies, these infants, do not do well in the setting of the wall-to-wall heart. The right ventricle has a big cavity, but it is a dilated cavity with thinning of the ventricular walls. As I say, the wall-to-wall heart is a very bad prognostic feature. You can, however, also have Ebstein's malformation when the right ventricle has a hypoplastic cavity. And here you see an example showing that. This is one that has a bipartite ventricular cavity, and you have minimal displacement of the septal leaflet away from the atrioventricular junction. And in this heart, the valve was probably competent, but if you have only an inlet cavity and the tricuspid valve remains competent, then the high pressure generated within the right ventricle, the suprasystemic pressures, lead to this problem. We have ectatic coronary arteries, and this is the consequence of fistulous communications and the right ventricular dependent circulation. So again, we know that these entities are a bad prognostic feature. Please do not describe them as sinusoids. They are not sinusoids. They are fistulous communications between the cavity of the right ventricle and the coronary arterial tree. They can communicate with all three major coronary arteries, and because the suprasystemic pressure is generated and carried on into the coronary arteries, it produces severe coronary arterial pathology. And as I say, the end result is what we call the right ventricular dependent circulation, another bad prognostic feature. And this is perhaps the worst example I have seen in an autopsied heart of the right ventricular dependent circulation. This was a child who sadly died at the age of 5 years. And if we blow up the base of the right ventricle, what you see here is a right coronary artery that is itself atretic. And this reflects the coronary arterial pathology produced by the fistulous communications with these ectatic coronary arteries, these pressure having a deleterious effect on the overall arrangement of the coronary arterial tree. Fistulous communications seen most frequently at the severe end of the spectrum, when the right ventricle typically has only the unipartite cavity, and this again, a bad prognostic feature. So we see the fistulous communications at the worst end of the spectrum, and almost certainly these patients who have fistulous communications, unipartite cavities, they are likely to be functionally univentricular. And to reiterate, it is a bad prognostic feature because the coronary artery pathology means that not only is the right ventricle grossly hypoplastic, the left ventricular coronary arterial supply is also severely compromised. But if we conclude our assessment of pulmonary atresia with ventricular septum by looking at the ventricular outflow tracts, the problems are not as great when we look at the intrapericardial arterial tree. Because what we see here, that at the better end of the spectrum, we can have a pulmonary trunk that is almost comparable in size with the aorta. And confluent pulmonary arteries in the setting of pulmonary atresia with intact ventricular septum are self-evidently being supplied by the arterial duct. But it is exceedingly rare to find other than confluent pulmonary arteries feeding all the bronchopulmonary segments. And there is a key to the size of the pulmonary arteries by the alignment of the arterial duct with the aortic arch. And this point was noticed a very long time ago, that the arterial duct points down into the descending aorta at the better end of the spectrum. This feature was noted by Dr. Santos, who worked with Elliot Scheinborn at the late 1970s. He came over from Brazil and he noted this point, that there is a difference in the alignment of the arterial duct relative to the aortic arch. So as the pulmonary artery gets smaller, still with confluent pulmonary arteries, the alignment of the arterial duct begins to change, and then at the worst end of the spectrum, and this is unusual, here you see that not only is the pulmonary valve atretic, the infundibulum is atretic, there is a thread-like atretic pulmonary trunk, but still confluent pulmonary arteries. But now look at the alignment of the arterial duct that is feeding those confluent pulmonary arteries. So the alignment of the arterial duct relative to the aortic arch is a hint as to the size of the confluent pulmonary arteries, which in this setting are fed by the arterial duct and feed all the bronchopulmonary segments. So what we can say is that the pulmonary circulation in this setting is almost always duct dependent. Very rarely you may find examples in which there are systemic to pulmonary collateral arteries, but in that setting you should suspect that a ventricular septal defect was present initially, but has closed itself during fetal life. And in the study that we did in the United Kingdom and ERA, where Steve Webber at the time and Piers Daubeny directed this study, and they found, collecting all the cases from the United Kingdom and ERA, we found 2 in which there were systemic to pulmonary collateral arteries. And when we examined those at autopsy, the evidence was very strong that initially there had been a ventricular septal defect, it had been tetralogy with pulmonary stenosis, which subsequently became tetralogy with pulmonary atresia. So the complexity in the setting of pulmonary atresia with intact ventricular septum is within the ventricles, whereas when we have tetralogy with pulmonary atresia, as you all know, the major complexity is in the pulmonary circulation. So the good news, there's not so much problem with the pulmonary arteries. The bad news, when you have severe hypoplasia of the right ventricle, almost certainly you are looking at a functionally univentricular heart. So what have I tried to tell you today? That pulmonary atresia with intact ventricular septum can be a functionally univentricular heart, but is not always a functionally univentricular heart. In those instances where we have a patent infundibulum leading up to an imperforate pulmonary valve, they are crying out to have the imperforate pulmonary valve opened up. That can be done by catheter, and that is the usual way you do things these days. And those patients certainly can move on and can be functionally biventricular. You have the gray zone in between with the bipartite cavities. It's up to you to decide whether the option should be functionally univentricular, functionally biventricular repair. But at the worst end of the spectrum, almost certainly we are talking about functionally univentricular hearts. And the evidence, as put forward by the fetal cardiologist, now shows to me, produces very nice evidence that what we are looking at is an acquired disease of fetal life, with a severity reflecting the time during development when something has happened to stop the ventricle growing, or rather to produce this abnormality with the pulmonary valve, whereby it either becomes severely stenotic or in the worst instances becomes atretic. And what we know is that part and parcel of this spectrum is hypertrophy of the ventricular walls, obliterating the ventricular cavity. But don't forget those cases that are also part and parcel of pulmonary atresia with intact ventricular septum, in which, during fetal life, tricuspid valve has been grossly incompetent. This has produced what we call the wall-to-wall heart. And in these instances, it is the squeezing out of the lungs, the effect the wall-to-wall heart has on pulmonary development, that is the major feature, again, bad prognostic feature. So if in the setting of pulmonary atresia with intact ventricular septum, we're looking at a functionally univentricular variant, that in itself is a bad prognostic feature. But then we also have the cases with wall-to-wall heart. So marked variability in the anatomic arrangement, but all to be understood on what happens during fetal life and on the function of the tricuspid valve.
Thank you, Dr. Anderson. It was a very, very nice session, and we could understand very well. We have a couple of questions on Q&A box. And please, guys, if you want to make any question or any